The Ontario healthcare system can feel like a maze, but today's guest is here to hand us the map. Whether you're waiting on a referral, struggling to find a family doctor, or just want to advocate for yourself without feeling pushy, this episode is your guide to getting the care you need. Welcome back to the podcast. I'm Tracy Mullen, and today I'm joined by my friend, Dr. Kaitlin Dupuis, a family physician with over 15 years of experience and a certified menopause practitioner. She's been on the front lines of women's health, surgical assisting, and metabolic care, and she's here to help us decode Ontario's healthcare system. From walk-ins to wait lists, she's got the answers we all need. Welcome, Kaitlin. Thank you very much for coming today. I really appreciate it.
So happy to be here.
Yeah, thank you. So there has been a lot of news lately about healthcare and wait times at the hospitals.
Mm-hmm.
Tell us, first of all, let's talk a little bit about how long you've been in medical care. 15 years.
Yeah.
How has healthcare evolved since you've been in the system?
Oh, so much. I think, one thing that really rings true in this span of 15 years has been the explosion of access to information. And so in terms of complexity of care, that has also blossomed, I think, in a good way, in that patients have more access to information. So they're coming in with more questions. There's much more information about different diagnoses. So it's been excellent in that way. But what has happened is the complexity has exploded and the resources have not expanded to match the ability of practitioners to care for that increased complexity.
Right. So we used to call it Dr. Google, and now we're calling it Dr. ChatGPT.
Yeah.
That's where everyone is getting their information from. It's fueling the fire for sure.
Yeah. You know what? To be honest with you, I'm not so opposed to AI. We can talk about that.
I'd love to.
Yeah. I'm not opposed to AI's involvement in medicine. In fact, I think it's going to be fascinating and extremely helpful when used appropriately.
It's going to be great for the doctors too, if they can use that system eventually.
Absolutely. I think one of the reasons why our healthcare system struggles is because we have not leveraged technology the way other industries have in order to streamline the industry and care. There's so many, and COVID taught us this, that there's so many things that can be provided virtually to prevent people from actually attending the emergency room. There's an interesting study through Sunnybrook during the pandemic. They opened a virtual urgent care to try and divert people from attending the emergency room, or to care for people who were too nervous to attend the emergency room but still needed urgent care.
Right.
And their preliminary study estimated that it diverted approximately 80% of people who would end up in the emergency room who didn't need to attend the emergency room. They had received adequate care through this virtual urgent care.
Wow.
So I think there's really interesting and innovative technologies that can be used to help reduce, in terms of, I would say the one that gets the most media coverage is the emergency room,
right,
in terms of wait times and access.
We're hearing a lot about that. And I know my father-in-law went last week. He was 10 hours in the waiting room at 87 at Sunnybrook. And that's just the reality of where we're at right now. Is it because so many people are going to the emergency room that don't need to be there? Is that part of the problem?
It's such a multifaceted problem. That's one of them for sure. And that stems from, not even recent changes, but policy changes that were made 20, 30 years ago that involved cuts to primary care and people's access to care that would, like preventative care, primary care, that would prevent them from needing to go to the emergency room. So there's that arm. There's sort of this expansion of our population that the healthcare expenditures and training and providers have not matched. So we have this disproportionate, people accessing care, too many people, and not enough resources to deal with it. It's not just a doctor problem. It's not just a physician issue. There's been cutbacks in almost every aspect of healthcare. So, I've had situations in the hospital that I work at where the emergency room is literally bursting at the seams. People are sleeping in the hallways, and up on the 10th floor, the beds are empty because there's not enough nurses to care for those patients. So people are in the emergency room who are admitted to the hospital because there's nurses in the emergency room that, are stretched beyond thin. they are not moved up to the appropriate floor when they're admitted because there's not enough staff upstairs to deal with them. So you walk around this 10th floor and it's like a ghost town. Meanwhile, downstairs it's chaos. So,
And this is all the things that people don't see behind the scenes, right?
yeah, absolutely.
So we've known each other. We should start there. We've known each other since approximately 2019.
Yeah, I think so.
Right?
Yeah.
And I am passionate about healthcare because I have 2 people in my family that are in medicine.
Yep.
And that's how we met.
Yep.
And so I kind of get the background of what goes on with the medical system.
Mm-hmm.
And what I see is that they don't just work a 9-to-5 job.
Yeah.
They are working behind the scenes. They are having meetings at night. They are doing so much paperwork.
Yeah.
Tell me about the paperwork. What's going on?
Oh, I think there's been a lot of media coverage about family medicine in particular, about the administrative burden and how much unpaid work there is. And we can talk about that in terms of family medicine and why for most family doctors, it just doesn't make sense financially to have a family practice in Ontario.
Right.
But it's actually across all specialties that the administrative burden. So in terms of you see a patient for maybe 15, 20 minutes and you have at least that much time in paperwork or more. You have to dictate the note. You have to arrange appropriate investigations. You have to make referrals. A lot of times there's a work note or a sick note that needs to go along with that needs to be written. It just piles on top. So, a lot of people will lament that their physician's not in the office 5 days a week. Mm. And I can almost guarantee you that it's not because they're taking like a ski day or a spa day. It's because they're taking a day to catch up on their paperwork, which is not paid.
Right. I went to a specialist appointment with my mom last week, and the specialist actually dictated his notes while we sat there and waited. I thought, well, that was pretty efficient. Mm-hmm. Yeah, so I guess there's ways to help, but
yes, yeah. I think, again, AI and leveraging technology is going to be huge. There's obviously some privacy concerns around digital scribes, but that's been, in the last year, that has really, really expanded within the medical profession. So having a recording device that's listening to your conversation and then afterwards is just scribing the note. And so then you don't need to write your visit note.
Like a lot of speakers will wear AI pendants. So why can't eventually a doctor wear an AI pendant, which would transcribe his notes right to the system? Absolutely.
Yeah. And I think, rightfully so. The medical system has a lot historically to answer for in terms of its paternalistic taking advantage of patients in some respects, whether it was for research or just because the doctor said that was what you were going to do and you weren't going to ask any questions. So I think people are rightfully suspicious of new technologies that are introduced in medicine and how it relates to their privacy. And so there's a few kinks to work out, but overall, I think it's going in a really positive direction.
Well, a doctor wouldn't be able to just use ChatGPT. They'd have to have a technology system that was just for the hospital.
Yeah, ideally. Yeah. And there's some really, even Canadian companies that are really doing exciting things with AI and access to care, reducing administrative burden, lots of exciting things coming down the pipe. Unfortunately, the funding is not flowing to match that.
Right. You said a couple of things. One, you said that things happened 30 years ago. So are we paying for cuts that happened 20, 30 years ago? Is that what's happening in the system right now?
Yes.
Okay.
Absolutely.
A lot of people are blaming all of that on immigration.
Yeah.
Obviously, we know that the immigration numbers have been too high and it has put a squeeze on the medical system, but that's not the only problem, correct?
Oh, absolutely not. No. I mean, immigration is a wonderful thing. We have so many skilled workers, even especially in healthcare, who come from countries other than Canada. They immigrate here. They are wonderful additions to the healthcare system, to our country. But what's happened is with the immigration push to bring these skilled workers into the country, we have not matched the healthcare resources to deal with the population. And when we introduce different types of immigration, obviously, if we have a large refugee population that's coming in, which is, as Canadians, we value that significantly, being able to provide a safe haven to people who are unsafe or persecuted in their home countries. As a Canadian, I'm very proud that our country does this, but it does put a strain on the healthcare system, and you cannot deny that, because oftentimes the people who access the healthcare system are the ones that are most marginalized. They have the highest healthcare needs, at least temporarily while they're getting settled. And by and large, we have not matched the resources to deal with the increased complexity and the increased needs.
Right. I think one thing that people don't maybe not know is how much education is involved in becoming a family doctor or a specialist. Can you talk a little bit about what the system is?
Sure.
Does it need to change?
I think I'm biased because I went through the system. So I'm like, well, this is the only way to learn how to be a physician because I did this, right? And I think that's a bit of a stubborn view. There's definitely room for innovation. There's some really interesting programs that have started where they're taking kids out of high school that kind of know they want to be in medicine. And then they're doing a little bit of it, like you do a 5 or 6 year program that's undergrad and medicine combined. And then you come out as a family doctor. There's direct medical school entry for those that know they want to do family medicine, and they can kind of streamline them in. So there's some really good programs that are starting. But by and large, I will say if someone had told me when I was going into medicine, you will be just fine financially. You will do well. You'll have a nice home, but you will have to budget and you will have to really watch your finances. If you want to be a millionaire, billionaire, you need to go into technology or finance, not into medicine. No. Because you will work for every penny. And the reality is that most people coming out are in their late 20s, early 30s. They've had delayed earnings, so they haven't earned anything. So now they're starting in their late 20s, early 30s, actually earning money.
To pay their student loans.
So most graduates are coming out with about $200,000 to $300,000 worth of debt at age 30.
Right.
So you're starting in the negative, and then if you're going to work until you're 65, you really have to hustle, right? Whereas people taking a different route would have started earlier, in their early 20s earning.
Right. So right now, anyone that's interested in medical school, the current system is a 4-year undergrad. Is that correct?
3 or 4 years, depending on the school. Yeah.
Okay. And then they get accepted to medical school. Yep. It's not easy to get accepted to medical school, is it?
Oh my goodness, no. And really, there's a few different aspects. One is the grade cutoff. So there's a GPA cutoff, and if you don't meet that cutoff, they're not even going to look at your application. And then there's standardized testing, like the MCAT exam, which most people know about. And most schools will accept this. Some schools will only accept, for example, McMaster that I went to, they just take one component of the MCAT, the verbal reasoning score.
Right.
But most medical schools want you to have the full MCAT. And then there's the whole piece where they look at your extracurriculars, your employment, your volunteer history, community service. And really those things are very subjective. So it just kind of depends on who's reading your application at the medical school that you've applied to. Yeah. So there's definitely a bit of luck that goes into it.
So how did you get into medical system? Do you have somebody in your family that's a doctor?
No, nobody in my family is a physician, similar to
my daughter.
Your daughter. Yeah. I'm in high school. There was this show that was on TLC, the Learning Channel. It was called The Birth Story. I was fascinated by this show. I would watch hours and hours of it. And I just thought, I need to be part of this. I want to be in the hospital. I want to deliver babies. So I sort of had this solitary mindset that was what I was going to do.
Right.
And I didn't know anything about midwifery at the time. I didn't have access to that information. I really thought the only way that I can do this is if I go to medical school and become an obstetrician. So that became sort of my solitary focus. I just worked towards that goal. So I did my undergrad. I applied after 3 years, did not get in anywhere, reapplied after 4 years and got in. So
very nice.
Yeah.
Not easy to do. So congratulations
Thank
on that.
you.
But now, why are you, so if you've been in medical or out of medical school for 15 years, how come you don't practice family medicine anymore? Let's talk about that.
Oh my goodness. Well, you'll need to be a bit of a therapist for this too, because there's been a lot that comes with this. And I think most people who train in family medicine in Canada really feel the same. And it starts with a bit, so just to back up, when I started medical school, I right away dove in obstetrics gynecology. This is what I want to do. And I did a rotation right in the first few weeks. And I was like, these people are surgeons. I don't know if I want to be a surgeon.
Right.
I'm not really sure about that. I thought, what am I going to do now? I kind of had this whole purpose that I wanted to deliver babies. So rotated through pediatrics and thought, oh no, I like kids, but I don't know how much I can deal with, really sick kids.
Right.
And then landed on family medicine, which I loved being able to establish that relationship with the whole patient and the whole family, and realized I could do lower risk deliveries within family medicine. So had the idea to practice family medicine and do low risk obstetrics at the same time. So that's how I ended up choosing family medicine at the end of the day.
Right.
So I started off in family medicine, just like most people who finish in the family medicine residency program. And very quickly, I would say we develop what is termed a moral injury. And that is, you've worked your entire life to provide care, excellent care, and there are constraints on being able to deliver the care that you want. So good care for me really is hard to deliver in 5 to 10 minutes. But I'm forced to do that because in order to pay my nurse and the administration at the front and my mortgage or rent on the clinic and the utilities and my supplies, I have to see at least 6 patients an hour. So I have to see a patient every 10 minutes or else I'm not going to be able to keep my practice running.
And is that just your break even point then? Or are you actually starting to make some money?
So that's why by and large people operate in group practices, because you would have to, so on average, a physician, according to the schedule of benefits in Ontario that pays physicians, a family physician's standard visit, a doctor to see a patient will make $37.95
Per patient.
per patient.
Wow.
It doesn't matter if that encounter is 2 minutes or whether that encounter is 1 hour. By and large, that is, and I should say there's little codes that go along with it. Like if you do a urine sample, that's another $5 or whatever,
Yeah.
but they're very limited. So to break even, you would have to see a patient, and of course it depends on the geographic area. If your rent is more expensive, obviously in Toronto than it is in a more rural place, but you would have to see a patient every 10 minutes, 8 hours a day, 5 days a week to pay your overhead essentially.
Right. Unless you get into group.
Unless you get into group and you share the overhead. So that's why most practices now are a group practice, because then you can split the overhead. So it's financially unsustainable, especially for people who have hundreds of thousands of dollars of debt to repay. And then what happens is it leads to this cycle where you feel like you have to work harder and faster and to pay in order to keep your office open. But increasingly you're taking less time with patients. You're, skipping on steps that I'll just do this, and then the next visit I'll bring them back and then I'll acknowledge it at that point, when really it's so much more efficient to just care for the entire patient in that one visit.
You're actually explaining to a lot of people that are listening right now why they're feeling so unheard when they go to the doctors, and why they are only allowed to have one question, because you have 9 minutes left, right? Once your question's done.
And I can tell you, in my medical school class, I can't remember a person who wasn't passionate about medicine.
Well, you have to be.
You have to be.
You have to be.
So it's not like these, people go into medicine thinking, oh, I'm going to ruin my patients' days. I'm going to make them just feel so unheard. And really we're working within a system that is burning us out.
Right. Yeah. So what needs to change?
Oh my gosh. If I had the answer to this, I would be highest level of government and it would have been fixed 10 years ago.
Right.
But again, it's such a multifaceted problem. We need more people in the profession. We need more funding. We need to establish what our priorities are for health in terms of our population. So I think a huge piece of family medicine has become putting out fires when it really should be about preventative care.
Right.
We need to do a way better job at putting out the fires before they start. So in terms of chronic disease management, that's really what family medicine has become. And we could do a lot better job if we had more time to spend on preventative health, is my humble opinion.
Do you believe in people that can afford to pay for private care paying for private care because they think they're getting out of the system to allow more people into the system? They feel like they can afford to pay it. So should they, or are they skipping the line?
The data doesn't support that offloading into the private system actually alleviates the pressure on the public system. So from a data perspective, I would the answer is no. From a practical perspective, I would say yes. Like if, my friends who have said, what do I do? Like I haven't had a family doctor in 15 years. I have no idea even where to start. Nobody's taking patients. I'm like, well, there are these sort of concierge medicine places where you can get really, really excellent care if you pay a couple $1,000s a year and you have access now to a physician. And it's a very individualistic way to look at things. And it really goes against at least my core of what I feel Canadian medicine is all about.
Right.
And that is everybody being able to access amazing care. But the reality of the situation is it's crumbling and you kind of need to grab a life vest. and for some people, that's going to be accessing the private system.
Right. So is the biggest concern that you have as a doctor right now is helping other doctors get fairly paid for their services that they're providing? Because it sounds like to me like $37.50 is not a lot of money for a 10-minute appointment.
So the Ontario Medical Association, which represents physicians, is fantastic in their advocacy. So they are the group that work with the Ontario government to negotiate in terms of rates. So there's been percentage increases. I think when I graduated, it was closer to $30 or $31. So it has gone up, but absolutely it has not matched the inflation rate whatsoever. So, as a physician, I've really thought about who I am because there's so many different types of physician. There's physicians who are amazing advocates. They're amazing physician leaders, physicians who are amazing with technology, physicians who are great with acute care, chronic care. I just love seeing patients. That's my passion. I just want to spend time with patients.
Right.
And my way of contributing to the healthcare system is to just provide really good care to the few patients that I can see.
Right.
That's sort of how I've come to terms with dealing with the system.
Right. Makes sense. And you and your husband now own your own clinic. Is that true?
We do. We share it. We're in a group with, there's 5 of us all together. Yeah.
And can you tell us a little bit about the clinic?
Yeah. So our clinic is called North Toronto Surgical. We are a group practice in North Toronto, in North York. And there are 3 vascular surgeons, 1 plastic surgeon, and then myself. I do women's healthcare, so sort of care across the lifespan, starting with contraceptive care, and then I also do menopause care. And people are always like, well, how does vascular surgery and plastic surgery and women's health all go together? And the answer is it doesn't, but it's just a really convenient way to share overhead for sure. And there is some really interesting overlap that happens. Like, a large part of women's health is, in like skin health has become huge.
Right.
And so that ties in with plastic surgery and, our plastic surgeon at the office, while she does have a cosmetic practice outside of her office, her practice is seeing skin cancers, doing hands, like minor procedures that you can do under local anesthetic for the hands. And that ties in really nicely with the population that I see that often will have sun damage or concerns about concerning lesions. And then with vascular surgery, varicose veins and lower extremity arterial venous disease is always topical for an aging population. So yeah, it does actually work quite well.
That's good.
Yeah.
Well, congratulations on that.
Thank you.
It's been a few years now.
Yeah. Let's see. My journey started in family medicine. So I worked in labor and delivery for a long time until I had my own kids. And I decided the only babies that I wanted to keep me up at night would be my own.
Your own.
And then I did a little bit in emergency medicine rurally, which was an amazing experience. And then we moved into Toronto. I again worked in family medicine and labor and delivery at Mount Sinai downtown. And then once I had my kids, I moved into adolescent health, primary care, and then decided that I wanted to branch out on my own. And so joined forces at North Toronto Surgical and opened my own sort of women's health program.
Very good. Well, we're going to talk to you one day about that.
Yes,
for sure.
Okay.
Yeah.
I'm excited.
Good. Talking about family doctors again, my doctor told me that if I want to go to urgent care, I need to go to one of the programs associated with his office, or else he got deducted.
Yeah.
What? Tell me how that works. I
Oh.
thought that wasn't true. I thought there's no
my
way.
goodness. Yeah. So I don't know when this program was introduced. It's been at least 15 years. And it was the introduction of a team-based approach to primary care, which really had a valiant mandate. And that was, let's join forces with as many family doctors as possible in these groups called either family health organizations or family health teams, and attempt to provide care for patients for most hours of the days in order to prevent visits to the emergency room. So that was sort of the mandate of these family health organizations. They didn't have to physically be in the same place. It could be, a family doctor on Main Street and a family doctor on West 5th Street and, within the same general area. But what would happen is you would have this group of physicians who would be providing after hours care. So you had to be open every single weeknight, and then I think either on Saturday or Sunday. And so doctors within this group, sometimes it was 10, 12 physicians, they would take turns having their office open. And so if you were Dr. Brown's patient and then you were going to, you had something at 7:00 on a Thursday, you could then call up Dr. Carter, who's not your doctor, but is linked with Dr. Brown,
Right.
and you could see them. And that, you would have this automatic link as opposed to going to the emergency room
Right.
for something that didn't need emergency care.
Right.
And the way to reinforce that was not to penalize patients, because really you can't control patient behavior. They're going to go where they're going to go, was to penalize the family physician if their patients sought care outside of that circle of care.
Well, don't you think they should tell us about the circle of care? Like, that's the first time I'd ever heard of that. Was recently. I was like, I just would go to urgent care. More convenient. I didn't have to make an appointment.
Yeah.
I had no idea that they were penalizing my family doctor for that behavior because I didn't know.
Yeah.
Yeah.
I mean, terrible PR. If we think back on that, really, not the message wasn't done well. When you sign in with a physician or a health team or family health organization, when you become a patient of that, if they're in that model, you are rostered with the patient. So most people, almost everyone, has had to sign something saying, I am rostered with this clinic. I will not visit outside walk-in clinics.
Right.
I will not see other primary care. But I've seen the page. I've signed the page. It's this really long sort of page that not super clear. And unless you have this frank discussion with your physician of like, you need to never attend a walk-in clinic or any clinic that is outside of these list of clinics that I'm affiliated with, or else what happens is if they visit a walk-in clinic, the family doctor is paid a certain amount each year to have a roster of patients. So per patient, not very much, to be totally honest with you, but there are certain stratifications of it. Like I think there's more if you've got an older roster of patients, for example. It's maybe $200 a year to have this patient on your roster. And if you visit a walk-in clinic, they will take that $37.95 and they will subtract it from that physician's billings.
That's the
so what
definition of
happens?
insanity.
Yes, it is. What happens is it pits physicians against each other, because you have now groups of primary care physicians who absolutely detest walk-in clinics. I think rightfully so. In terms of walk-in clinics, it's very hard to provide good continuity of care.
Right.
But also because it's taking their paycheck. So they're really defensive about it, rightfully so.
Well, especially when the paycheck for their education and all they've put into it.
They've got bills to pay.
Yeah.
So if they've budgeted that this is how much we get per patient and now it's being clawed away. So the good news is OMA has done a lot of advocacy around this, and there is talk that this system, which is called negation, will be terminated sometime in 2026.
Oh,
so that patients will have more freedom of movement throughout the healthcare system, which is good, but also not great, because as a patient navigating the system, it is better to have all of your care in one place. We know that from outcome data across the world, that if you seek your care in one location and all your records are there and you establish a relationship with a provider, your outcomes are much, much better than if you're sort of cobbling together care. Yeah. So.
Let's talk a little bit about people that can't find a family doctor. What can they do?
So pretty much half of Ontario or more. And really this is replicated across Canada, and different provinces are in different dire need. Like, for example, Prince Edward Island, tiny province, but terrible access to primary care. So it's not just an Ontario issue, it's sort of a Canadian issue. If you don't have a family doctor, I would say, and you're in relatively good health, your number one priority is figuring out what you need to do from a preventative care standpoint. You can leverage technology for this. So you can use AI to say, I'm a 52-year-old healthy female. What preventative care screening do I need to have done? And it's gonna put out for you, well, you need a screening mammogram once every 1 to 2 years starting at age 40, according to Ontario guidelines. You need to have annual blood work done for a fasting glucose, a hemoglobin A1C to monitor for insulin resistance or diabetes, cholesterol. Like, it's going to tell you all of that. And then you can access care, even walk-in clinics. You can go in and say, look, I don't have a family doctor. These are all the things that I haven't had done and I need these done. And they're going to be able to help you navigate that. The wrong place to go is the emergency room.
Right.
Do not go to the emergency room. But the reality and sort of, I worked in the emergency room 10, 12 years ago. The situation, especially after COVID, has become increasingly devastating. So I say this anecdotally with my friends who have done emergency medicine, and some of them have left, unfortunately, emergency medicine because of burnout. But they are seeing devastating impacts and consequences of people showing up to the emergency room who could have had this prevented with appropriate preventative care.
Right.
Like metastatic breast cancer, terrible outcomes, right? So if you don't have a family doctor, I would say the number one step is to figure out what your individual health needs are from a preventative standpoint. Obviously, if you already are dealing with an illness, you need to kind of figure out who is going to quarterback your care.
Right.
If that's a really great walk-in clinic doctor that you see, just try and go to the same place every single time. Virtual care is interesting. It has done some amazing things. There's definitely been some problems with it. It's like any new technology. There's things that needs to be ironed out with it. But if you're on a chronic medication and you need refills and someone to monitor things, virtual care is really appropriate if you don't need a physical exam for it.
Right.
So one of the things is, you're a young woman and you need birth control. Going off your birth control because you don't have access to a prescription is a real health issue. You can access virtual care for that. And then we usually will do a blood pressure every year just to monitor blood pressure on birth control. And what I tell patients is when you go to pick up your prescription, squeeze your arm with the blood pressure machine at the pharmacy. If it reads over 120/80, make another appointment. We'll chat. So there's innovative ways to get around those.
This is almost like advocating for yourself without having a doctor. You're going online to figure out, what do I need to do?
Yes. Yeah, absolutely. I mean, I think patients Googling and coming in with their diagnoses already and stuff they saw on TikTok and
my friend said,
my
we
friend
always say my Aunt Betty said.
Yeah, right. I mean, that has tortured me to no end. I'm not going to lie about that. And I think a lot of my colleagues and friends will say that medicine has really become sort of 50% defending medicine and 50% therapeutic. So we spend half of the time talking about why this intervention that we're proposing is actually totally safe and fine, even though on TikTok it said something else. Right. So there is sort of this combative element with patients. But again, I can talk to that too. Medicine has a lot to answer for in terms of being paternalistic and abuses of patients. So I understand where it's coming from. But Google and the internet and social media can do some good if it means that you are learning more about your health, you're learning how to advocate for yourself, because you have to advocate for yourself in our system, unfortunately.
Right. That's a big topic. We could just spend all day talking about that.
We could spend all day. Yeah.
Tell me about hospital care and who should go to the emergency room and who should not go to the emergency room. Because when you go there and there's a 10-hour wait, there's probably a lot of those people that could have gone somewhere else to get their care.
Yeah. I think the reason why we haven't nailed this is because there are what we say red flag symptoms, like do not pass go. You are going to the emergency room, any sort of chest pain, shortness of breath, stroke-like symptoms, any cognitive change. That's emergency room.
Right.
Or 911, an emergency room, right? But there's so much that lies in the subjective in terms of, I've had this fever and I have this cough and sometimes a little short of breath, but I don't know, could that go to a walk-in? Could that go to an urgent care? I don't know. I'd have to examine you and I'd have to get the full history. So I do think it also depends on region, right? So in Toronto, for example, or in, a bigger city like Ottawa, you have a lot of options for care. Whereas if you're rural, your urgent care is probably your local emergency department. So it's a little bit difficult. I wish I had a nice crisp answer for you of like, this is what always goes to emerge. This is what always goes to urgent care. But, there's a few pearls. Like if you have a cut, like you've cut yourself and you think you need stitches, can't really wait 24 hours because at that point the wound started to close and you can't stitch it at that point. So, there's a few things where you need to visit more urgently, an emergency department or urgent care. But prescription refills, things that if you think about, well, would I be okay if I waited 24, 48 hours? That means do not go to the emergency room.
Right.
And I don't say that only just to unburden the healthcare system. I say that because I want to impress upon people that, and most people know this already, sitting in an emergency department for 10 hours is probably one of the worst things you'll experience.
Right.
It's just not a great place to be. Unfortunately, with our system, the emergency room has been a catch-all for everything that has happened in our society. So obviously we have the medically acute patients that are going, the heart attacks, the traumas, the strokes, but you also have a very large population with mental health crises that, some places they've done really interesting things where they've started psychiatric emergency units so that those patients can be appropriately triaged and sent to a separate, quieter emergency department. It's more appropriate. A huge addictions issue, which again, we could spend hours talking about. And then we have a rapidly aging population and complex healthcare needs, cognitive decline, and those people, to make them sit in an emergency room for 8 to 10 hours as either the person who's dealing with that, the patient themselves, or a caregiver, is torture.
Yes.
And some places have, again, created a fast track unit. So people with cognitive decline or dementia are sort of whisked to this other area of the emergency room where it's quieter, the lights are down. It's just a recipe for success as opposed to recipe for disaster.
Right. I think a lot of people from like Durham region where we're located today are also thinking that the hospitals in Toronto are better. So they're going to Sunnybrook, they're going to take their kids to sick kids. Yep. Is that overburdening Toronto?
Oh, I mean, I don't know. I don't know the data exactly. I think ideally the Ontario government has catchments where your postal code determines where you should be accessing care. But again, it's really hard to mandate that patients, it's impossible to mandate people, like you can't control people's behavior. I don't know the answer to that because I think it is extremely variable. So there were times when I was working in Emerge rurally where certain times in the morning we'd have a 30-minute wait. And then at certain times we'd have an 8-hour wait. And it just kind of depended on what was coming through the doors that day. So I think it's variable. I don't know if I have a great answer for you.
Okay, that's fair. So what about if you were in charge today? What would you tackle first? Would you tackle like the education system and make it easier for people to be doctors? Because it's not easy to be a doctor in Canada.
Yeah.
What would you do? What would you do first?
I think if I were to, oh my gosh, again, I like,
That's a tough question.
yeah. Oh my gosh, what if I get hired to, lead the health, like the entire
You're ready for
Federal
it.
Department of Health? Yeah. I think I would start with figuring out the priorities at the government level because funding it affects everything. So are we prioritizing frontline care? Are we paying nurses appropriately? Are we putting enough doctors and nurses and technicians into the system? Where do our priorities lie as Canadians? And then figure out where funding is going. Because right now I can say that every area is a silo. They don't work in connection with each other. So this hand is not talking to this hand. And so what ends up happening is there is wasted expenses. So if I was going to go top to the top, I would make sure that we had figured out what were our priorities and direct our funding there.
Very good.
Yeah.
That's amazing.
Yeah, because I don't think sending more doctors into a system that doesn't have enough nurses is going to solve the problem.
True.
Or, sending more healthcare practitioners into a place that doesn't have enough hospitals to do surgery or admit patients. And
think about how many schools have been added in Ontario.
Absolutely.
But what about the hospitals?
Yeah.
Why are we not building new hospitals?
I think that is a question a bit beyond my scope. We have had some new hospitals built in Ontario in the last decade.
Publicly funded, right?
Yeah. Oh, yeah, absolutely. Yeah.
And then some of them donor one. Was there not one in Newmarket recently? Newmarket?
I don't know. I mean, donors get very heavily involved in every aspect of hospital growth. I mean, I'm at Humber River, so I know there's a really huge fundraising and donor program there. So most hospitals will have a large donor program. That's why you see people's last names on the side of the towers. Because
now you're seeing the hospital names with the donors' names.
Absolutely.
Yeah.
Yes. Yeah. So, I mean, it cannot work on government money alone. But yeah, the building is only one piece. You have to have the staff. You have to have, and when I say staff, I don't mean just doctors and nurses. I mean, the healthcare system only works because every single part works together. Like if you don't have a porter in the hospital to bring the patient from the emergency room to the operating room, your system falls apart. If you don't have housekeeping to do terminal cleans of someone with an infectious disease that's now discharged to bring the next person in, your system falls apart. So it is a massive system of different professions that need to come together for a healthcare system to work flawlessly.
You've given us a lot of really good information today. Thank you.
Hopefully some hope too.
Well, let's talk about hope. What? So for people that are having some, a critical illness, a terminal illness, how do they find hope in this if they can't get the care that they feel like they deserve or they need?
As much as there is bad news about the Canadian healthcare system, I will say that there are a few areas where we shine. Again, there are always isolated cases, and you'll hear about these in the news where the system has failed. But by and large, if you are very ill in Canada, whether it's trauma or a severe life-limiting illness like a cancer, you will be well taken care of.
Yes.
Our system works. Like you have a car accident on the 401, the ambulance is going to be there. You're going to be taken to an amazing tertiary care hospital where everything is going to flow and you're going to be given your best chance because the system is among the best in the world when it works really well. And we're really good at putting out the fires.
Right.
It's just the steps before that
you're talented, you're professional, you're getting the best education in the world, one of the best educations in the world. So things have got to get better.
Oh,
for sure.
Absolutely. And I think too, it depends on patients knowing the things we've talked about today and advocating for themselves and the system that they want to see. And so, I think it's very complex. And again, I think the reason why it hasn't been solved is because it's so complex and that's why we're struggling. But I can tell you there are so many good people working on this problem. So many smart people that I know from medical school and my colleagues and really passionate people about health equity, Canadian healthcare, patient care, doing good work. So overall, it's very positive. We are very lucky.
Good. Well, I have 4 grandkids, so hopefully as they're growing up,
Yes.
they're going to get better care,
Yes.
faster timelines.
Yep.
That's what the hope is.
Yeah, I mean, when you look at our statistics, and you look at even in the last 100 years, how far we've come in terms of infectious disease and child mortality. Unbelievable. Like there has never been a decline in infant mortality at the rate in the last 100 years as the rest of history. So we have a lot of really good things happening. But unfortunately, the bad things get the headlines.
They're all getting a bad rap right now, for sure. So can we talk about what should someone do when they're going to a specialist appointment? How should they prepare? Because some people just show up and...
So I would say as a family physician who practices with consultation. So I will have family physicians refer to me for menopause care or for contraception, insertion of IUDs or contraceptive implants or whatever. What I receive from a family doctor varies widely in terms of what information I'm provided about the patient. So I always love when patients are really well prepared with medication lists, allergies, and your past medical history in terms of diagnoses. Like if you've had major surgery, if you have had a major diagnosis in your past, have that ready. Even, like written down is even amazing, and you can slide that across the table. So in terms of that preparation, I would say that is the bare minimum. Really, physicians and specialists want to know. They want to know the story, but they will decide what details are relevant and they will ask you those pertinent details. So going into sort of this launch of 10 minutes of your story, I think patients think that's helpful. And I certainly have done it when I've gone to a physician, right? As I'm like, well, let me tell you exactly everything that happened since the day I was born that might contribute to this illness. And really, they will tease out what is important. So being able to say, this is what you're worried about. These are what the most concerning symptoms have been and how long they've gone on for. Those are the big ones.
Right.
Yeah.
That's really good. Very helpful.
Yeah.
Because I know when I have a specialist appointment coming up.
Okay.
And I was like, okay, well, now I know I have to prepare for this. It's like homework.
Yeah.
Right.
Yeah.
Okay.
So if I'm, say I'm going to see a rheumatologist because I've had this unrelenting joint pain and I don't know why I've had it and I've had it for the last 6 months, I would say to them, I have this really unrelenting joint pain. My mom has terrible arthritis. I'm really worried that this is what this is. It's been going on for 6 months. It's always worse at the end of the day after I exercise. I want to know what's causing it and what I can do to make it better.
Easy.
Well, sure.
Well, but one thing is, what I've seen is that the doctors who are at the hospital, especially their level of taking your history, they'll know what to ask you, right?
Yeah, we've been practicing it day in, day out, multiple times a day. So we know, could this be arthritis? What are all the other things and the really bad things this could be? Because we're going to make sure, first of all, that it's not those things, right? We're going to look at the things that are going to be potentially life-threatening. Those are the first ones we're checking off. So we're going to ask you those questions. So you don't have to do that for us. Like we will investigate to figure that out.
Right. But come prepared. It's the best thing you can do to go to an appointment.
Yeah.
So let's do our rapid fire. Are you ready?
I'm ready.
Okay. ER, walk-in, or urgent care? The one that's the most overused.
Oh, ER.
Yeah.
Yeah. ER is the last safety net in the system. So that's the one that catches everyone that's fallen through every single crack above that. So absolutely emerge would be my answer. One
thing every patient should keep in their wallet or phone?
Oh, emergency contact. Especially, even not in trauma or emergency situations, but even we've had patients be admitted and there's a language barrier and we don't know who to call. They can't tell us. So having emergency contact on your phone or on your person is huge. And identification. Okay. Really helpful.
Worst health advice you've ever heard online from Dr. Google?
Oh my goodness. There's so many. I mean, any sort of restricted diet. I don't love that. I've had patients on, and I'm sure you'll get heat for this because there's every diet in the world. And so I'm going to single one out, but I had a patient, just a particular anecdote. I had a patient who was on a carnivore diet. So only ate raw meat, only ate like raw steak, all day, and came to me because her periods had stopped and she didn't know why. And so we did a full workup. And what had essentially happened is she was right. There was nothing wrong other than centrally in the part of the brain that controls reproductive hormones had gone quiet because it interpreted that she was starving.
Right.
So that's the first thing to go is your reproductive function will go quiet because if you're starving, you don't want to get pregnant, right? Your body won't support it. So she had essentially stopped her period from eating a carnivore only diet. Yeah.
It's funny because there's so many podcasts or books that you can read now, and there's every diet in the question out there. Keto, carnivore. I'm a pescatarian, so somebody eating only meat is like, what? Yeah.
I mean, and diet is, from a research standpoint, is the most problematic thing to study because there's no consensus. There is no consensus that this is the diet for every single person on the planet. This is exactly what you should be eating. There's so much variability. We know, but there's a few themes. One is that in most countries in the world, we eat too much. So excess of calorie has now replaced the starvation that was the concern up until probably about 100 years ago for the majority of people on the planet. But we're now in a state of calorie excess. So fewer calories is probably better. But in terms of what to eat, the data is very conflicting.
Right. Well, won't your body tell you, like this lady that's her period stopped, the body's telling you this diet doesn't work for my body? Yes.
I mean, I think there's a lot of times diet is not like I will eat this and I'll feel terrible instantly. And that's the clue that I shouldn't eat it. It's a death by 1,000 cuts. Yeah. So we know ultra processed food in the long term will give us terrible health outcomes. It's been associated with colon cancer, diabetes, all of these end stream terrible diagnoses. But in moderation or a tiny amount of ultra processed food, probably okay. And we have to be realistic about how we live and the society that we live in. And the Industrial Revolution made us so that we're getting up now at 6 o'clock in the morning and we're working all day and we don't really have time to sit down to a nice family meal. And so we're working within systems that tell us sort of how we need to eat and what we should be eating. So,
and convenience become a big thing.
Yeah.
Most underrated healthcare professional.
All of them.
All of them?
I said this earlier, is that without each one, the system wouldn't work. It would fall apart. Like I can't be a doctor without support of my administration, my nursing. When I send my labs I get the patient go for blood work. Where are they going? Who's drawing their blood? Who's the pathologist looking at their sample? So they're all underrated. They're all performing jobs that are necessary.
It's a team event.
Okay.
Yeah. Favorite medical TV show, even if it's not realistic?
I will say I do love Pitt. I did love Pitt. It's intense, but I would say overall it's done a really good medically accurate job. But I'm very loyal to Scrubs because it took the serious side of medicine, but there was also such a fun, playful side, which, there is a lot of fun in what we do. I laugh so much with patients. My team, we all have a really good time together. There's lots of silly, funny things that happen throughout the day. And it has to be that way or else you wouldn't survive.
No. Yeah. I get all of my medical knowledge from Grey's Anatomy.
Yes.
Yeah.
Perfect. Yeah. And probably, it made you feel terrible about your romantic and dating life because these people are always, that did not happen. Although I did meet my husband in the hospital.
Oh, so it does happen.
I can tell you the call rooms are not like that, okay?
Good. Thanks for letting us know.
Yeah, of course.
Stethoscope or digital chart, what do you reach for first?
Oh, I have a bit of a corny answer for this.
Why?
Because, I learned with a stethoscope. And the digital chart is, I need access to that information. But my answer is the patient.
Oh,
That's where I'm going to find most of the information I need, to be totally honest with you.
right.
So you need to talk to the patient. That's my number one tool for diagnosis is the patient history.
Well, that's why you're so passionate about people navigating the healthcare system.
Yeah, I guess
right?
so. Yeah.
Well, thanks for joining us today,
My
Kaitlin.
pleasure.
And
It's
where
so
can
fun.
we find you?
So I work out of North Toronto Surgical, which you can visit our website, northtorontosurgical.com. Some of our services are referral only. So seeing one of the surgeons, you do need a referral from your family doctor or walk-in clinic, but my services, you can self-refer. I have a not a huge social media presence, so I don't have my own Instagram or TikTok or anything like
Right.
that. But North Toronto Surgical has its Instagram profile, so at North Toronto Surgical.
So we can read your bio there.
Yeah, absolutely.
Perfect. Yeah. Okay, thank you. Well, if you've ever felt overlooked, overwhelmed, or unsure of where to turn next, this episode is your reminder that you're not powerless. You can find all of Dr. Dupuis' information in the show notes. And if this episode helped you feel more confident navigating the system, share it with a friend or a loved one who needs it too. Thanks for listening. And until next time, just keep asking questions and advocating for your health. Till next time.